maybe us uncommonly. This topic is not so common. I mean, not a must-know chapter for you. So I'll start. So the most common risk factor is cigarette smoking. The smokers are 4 to 7 times more likely to develop bladder cancer than non-smokers. More seen in elderly age group. So uh, when more than 70% of people with bladder cancer are older than 65 years of age, men 4 times more likely, very unlikely to have a bladder cancer in female in a clinical setup. But when you have a woman having with a bladder cancer, the likelihood of death increases in women more as compared to men. That's the only difference. Otherwise, prevalence wise, men are 4 times more likely to develop bladder cancers. White people more than twice as likely to be black people, but again, black people are likely to die twice as I mean, death is 2 times more common as compared to white people. Maybe because of the genetic predisposition, maybe because of availability of healthcare, whatever reason. Chemicals form a very important part of etiopathogenesis of bladder cancer. Chemicals used in textiles, rubbers, leather, paint, some naturally occurring chemicals, aromatic amines, all increase the risk of bladder cancers. They have been found that the risk of bladder cancer in these textile industries, rubber industries is very high. Chronic infections, chronic UTIs, bladder stones, they cause dysplasia of the wall of the bladder, which causes changes in the lining, which is normally the transitional cell epithelium, which becomes more dysplastic and later on develops a squamous cell carcinoma. Even those who are paralyzed, those who have got paraplegias, because the indwelling catheter and recurrent UTIs, chances of getting squamous cell carcinomas is very high. Cyclophosphamide, again, a chemotherapeutic drug, have been seen to a high risk of developing bladder cancer. Pioglitazone, which is a anti-diabetic agent, and US FDA has said that used more than 1 year, they have a higher risk of developing bladder cancers, though this has not been proved 100% in all the trials. Recurrent bladder cancers is already high, and especially if the patient has had a cancer in somewhere else, like a urothelial cancer of the renal pelvis or of the ureter, they also have a likelihood of developing a bladder cancer, especially because of the field change. The same urothelium lining is seen in all the areas. Schistosomiasis, this is seen in Africa, Egypt, all these countries. And this parasitic infection against squamous cell carcinoma is very high. Some genetic syndromes, Lynch syndromes, they've got a genetic predisposition of increasing risk of developing bladder cancers. Arsenic exposure, this also, when you consume areas where arsenic is found in the soil and which water is contaminated with high levels of arsenic, there the risk of bladder cancer increases. Clinical features, the commonest clinical feature is obviously painless hematuria. Sometimes patient complains of passage of blood clots in the urine. The shape of the blood clots sometimes tells you that where the source of the bleeding is from. Because of the size and the shape of the bladder, most of the time the bladder clots are rounded. Sometimes they can come with clot retention because of a huge bladder clot which is obstructing the external opening of the bladder, internal opening of the bladder. If you have got a long tubular clot, chances are the bleeding is from the renal pelvis area, and that is why it is taking the shape of the renal pelvis or the ureters. So the shape of the bladder clot, sometimes if you ask the patient and if they're able to give you the shape of the bladder clot, then that tells you about the source of the bleeding. Sometimes microscopic hematuria may be seen in as a routine investigation. You're doing urine examination and then you start investigating these patients. Pain or burning sensation, frequency, nocturia, hesitancy, low back pain. Low back pain is sometimes associated with advanced disease where the malignancy has already spread beyond the bladder and involved the nerves. but most of the other symptoms are very non-specific, and it's difficult to attribute to straight away to carcinoma bladder other than hematuria. When you have a patient of hematuria, you start investigating these patients to rule out bladder cancer, especially if they're in the early stages. Those pathological types, the classical is urothelial or transitional cell carcinoma, which accounts for around 90% of all bladder tumors, and renal tumors, that is renal pelvis tumors or the ureteric tumors, they are just 10 to 15% of all renal tumors are urothelial or transitional cell carcinomas. So higher up, they are relatively uncommon. But the next variant is squamous cell carcinoma. We talked about squamous cell carcinoma in schistosomiasis, in chronic stones or chronic inflammation. They account for around 4% of bladder carcinoma. Adenocarcinomas, they are the least common. They are usually seen in the trigonal area, the entrance of the vitreointestinal duct. So in the area of the dome, they are common, where the urachal remnant is seen. That is the area where adenocarcinomas, the cell of origin is a adenocarcinoma. That is why adenocarcinoma occurring from glandular cells is seen in that area. Otherwise, normally the bladder does not have any glandular cells. And squamous cell carcinoma is also more common in the trigonal area. Less common, sarcomas, small cell bladder cancer. They are very uncommon. So usually we don't talk about them so common, but yes, sometimes rarer varieties are diagnosed either on the your bladder biopsies or sometimes on your when you send a specimen for total cystectomy specimens. Another method of classification is based on the level of invasion. So you can have a non-invasive, that's a superficial carcinoma in situ or polypoidal lesions, which is restricted to the mucosa. Non-muscle invasive bladder cancer, they are also labeled as superficial bladder cancer. They don't enter the muscular propria of the muscle. So because this classification is important, because this changes the type of treatment and the prognosis of these patients. Non-invasive bladder cancer, usually it is very difficult to diagnose because they may not have symptomatics. You might be doing a cystoscopy for some other reason, or as some other symptom, and then you diagnose suspicious area where you take a biopsy and they come out with carcinoma in situ. Sometimes they can be found as flat lesions, and sometimes they are usually diagnosed if you're doing a TURBT, that is transurethral resection of bladder tumors, as a staging as well as a therapeutic procedure. If you have got a carcinoma in situ, then it is called a TIS. Non-muscle invasive, like I already told you, it's called a superficial bladder cancer. Muscle invasive is the another variant where it has already grown to the bladder muscle wall and sometimes outside the wall also. And they are if they are diagnosed on imaging itself, then the patient should be counseled for a radical cystectomy on the outset. But if they are diagnosed once you have done a TURBT, initially we thought that it was a superficial tumor, and once you do a TURBT, that's, I said, it's a staging procedure also that tells you about the muscle wall involvement. So you start you get the confirmation of the biopsies, and the biopsy tells you that it has invaded the muscle. Then also either they receive chemotherapy or they are counseled that if they have a recurrence, then they should undergo a radical cystectomy, total cystectomy. And if they are involved into the change the slides. If they have involved into the surrounding organs like uterus, prostate, vagina, the pelvic muscle, they are called a locally advanced disease. TNM, I have written it just to complete the list, you need not remember all the TNM, but yes, if you just remember that there's superficial and muscle invasion and non-muscle invasion bladder tumors, that is sufficient for a level. So TX primary cannot be evaluated. Maybe the patient has received chemotherapy, or maybe the patient has deformed bladder. T0, there's no evidence of primary tumor. TA, this is a non-invasive papillary carcinoma. This can be easily removed by TURBT. Carcinoma in C2 or a flat tumor. T1, the tumor has spread to the connective tissue called the lamina propria, but the muscle does not get involved. T2, the tumor has spread to the muscle of the bladder wall. T2A is the inner half of the muscle of the bladder wall, which is the superficial muscle, and T2B is the deep muscle. T3, it has reached up to the perivesical tissue, which is the fatty tissue around the bladder. T3A, it is perivesical tissue microscopically. So this is diagnosed when you have done a radical cystectomy. T3B, it has involved the tissue macroscopically, that is mainly when it is seen on imaging. T4, that is a locally advanced respect to the abdominal wall, pelvic wall, prostate, seminal vesicle, uterus, vagina. So T4A is again, it has spread to the surrounding tissue. T4B, it has spread to the pelvic wall or abdominal wall. Lymph nodes, NX, the regional lymph nodes cannot be evaluated. N0, the cancer has not spread to the regional lymph nodes, which include the hypogastric, obturator, iliac, perivesical, pelvic, sacral, and presacral lymph nodes. N1, the malignancy has spread to one regional lymph node. N2, two or more regional lymph nodes. N3, the cancer has spread beyond the regional lymph nodes, that is a common iliac lymph node. M, distant mets. M1A has spread only to lymph nodes outside the pelvis. And M1B has spread to the other organs of the body. So once the patient has come to you, you have to establish the diagnosis. Only then you can stage the patients based on the staging system which you have just written about. So the easiest diagnosis is by urine analysis. And urine cytology, it is said that if you're doing a urine cytology for tumor cells, you take a evening sample. Normally for cultures, we ask the patient to give a early morning samples where the chances of growth of that organism is very high. But here, because the patient, when the patient walks and performs normal duty, the chances of shedding of the tumor cells is more. So evening samples are preferred, and you see them under direct microscope, and it's called a urinary cytology. There are other urine tests where molecular analysis is done. So based on the the molecular genetics of the cells, you can sometimes diagnose. Though the molecular analysis, they are not 100% specific. A lot of false positive reactions, false positive results are also seen with these, but they are easy to do. They can be done similar to, they are just similar to a pregnancy test. You have got a card, you just put a urine and you get the result. So they can be used as a screening test, though there's the cost is still very high for all these screening tests. So it is uh, not in vogue as a regular use for as an outpatient department procedure. The gold standard is cystoscopy and biopsy, and sometimes you can take a bladder during the cystoscopy, and that fluid might be analyzed for malignancies, especially if you've got a very superficial lesion and you can't take a biopsy or not sure about the site of the biopsy. You can do this. Otherwise, if you see a suspicious lesion, best is to do a cystoscopy and biopsy. In this context, TURBT and biopsy go almost hand in hand. Most of the centers perform TURBT, that is a transurethral resection of bladder tumors. That will be done as under anesthesia as a daycare procedure that will not only diagnose the bladder tumors, but for superficial bladder tumors, it will be therapeutic. And once you take a biopsy, normally a layer of the deepest layer is sent separately as a specimen, so that the pathologist is able to tell you whether the tumor has entered that layer or not. So if it has entered that layer, then obviously it's a muscle invasion. That is how you label the patient as muscle invasion and muscle non-invasive tumor. Other imaging studies are computer tomography or MRI. MRI is said to be better for pelvic lesions in the pelvic organs. So a lot of times MRI is nowadays preferred for showing up the site and the local extent. The lymph nodes, local extent, everything can be equally identified by CT and MRI. So more or less is the surgeon's preference or the radiologist's preference what investigation to be done. PET-CT, controversial as an upfront investigation because one, carcinoma bladder is localized to a large extent for a long time. So systemic spread is very uncommon with carcinoma bladder. So as an upfront investigation, usually it's an overkill. Treatment part, the mainstay of treatment is surgery. Chemotherapy, immunotherapy, you can have a local or a systemic immunotherapy. Then nowadays you have got targeted therapy, radiation therapy. It has got a lot of side effects, so it is not very commonly used for carcinoma bladder. But I'll tell you that radiation therapy later on once we complete the rest of the treatment plans. So for surgical part, non-invasive or non-muscle invasive tumors, TURBT is the treatment of choice. Then you have to give them intravesical BCG, that is Bacillus calmette-guerin, as immunotherapy. This is the local immunotherapy. Or you give intravesical chemotherapy like mitomycin C. This is again a local intravesical. So this is not acting as a systemic chemotherapy. They will be acting as local immunotherapy. It is said that they will kill the superficial tumors if you have not taken care of. Sometimes field change is seen in the rest of the bladder. These tumors may not be picked up on your routine CT, or even during biopsy you may not have seen them. So this will take care of the rest of the tumors and prevent a local recurrence. Muscle invasive, the first is obviously TURBT, where you do it as a staging and as therapeutic also. If found invasive, they have to be told that either they go for an upfront radical cystectomy to begin with, or they can wait for a local recurrence. In the meantime, you give them chemotherapy and systemic chemotherapy, and if they are keep them under regular follow-up. If they don't develop a recurrence, the patient bladder might be salvaged, but if they land up with a recurrence, radical cystectomy is the treatment of choice. Muscle invasion, if you have a muscle invasion on CT or an MRI upfront, then they should undergo a radical cystectomy. They should be counseled for a radical cystectomy. They are not a candidate. They are not candidate for TURBT. Systemic chemotherapy, the commonest regimen is MVAG, that is methotrexate, vinblastine, doxorubicin, also called adriamycin, and cisplatin. This is given as a systemic agent, and this is preferred in patients where you have got a locally advanced disease, that is, it has spread beyond the bladder, or maybe the muscle is already involved. You can start them with chemotherapy and downstage the disease. The outcome of surgery is better. That is why this is given as a systemic form. Sometimes after radical cystectomy also, you can give them just for preventing the development of micrometastasis or local recurrences in the near future. Targeted therapy, very few drugs like erdafitinib have been given in patients with locally advanced or metastatic carcinomas. This is after failure of your standard chemotherapeutic agents. This is targeted against DNA changes in FGFR2 or FGFR3 gene. So in these patients, these genes have to be first tested. Only once they are found to be positive, only then you can use this agent. This is not a, routine agent used. Most of the time it's used as in form of a trial only. radiotherapy, I said that radiotherapy will talk liver. Radical radiotherapy, where patient refuses to undergo a surgery like a radical cystectomy, says I want to preserve my bladder. In those cases, you can give a radical radiotherapy, but the amount of dose to kill the entire bladder tumor is so high that it actually causes so much of fibrosis of the bladder that patient lands up with a very small or a very fibrotic bladder. So the life outcome after a radiotherapy is very bad. So over the years, radical radiotherapy for treatment of carcinoma bladder has gone out of use. But yes, you can use radiotherapy after resection of the bladder tumor to in the bladder tumor bed, so that you can prevent a local recurrence. So as a adjuvant radiotherapy, you can use them, but as a radical radiotherapy, as a therapeutic radiotherapy, it is not a treatment of choice. So the next topic is, once you have done a radical cystectomy, the urine has to come somewhere. So urine goes as a diversion. You have to divert the urine now. So the diversion is done either in the ileum, so it's called an ileal conduit, or sometimes in the colon, which is called a colon conduit. So this the ileum is the most common form of diversion, and ileum is used, and the urine, I mean the ureteric openings are anastomosed to the ileum at one end, and the other end is brought out of the abdominal wall as a stoma. And then you put in a bag over that stoma, and it has to be emptied every 2 to 3 hours or every 1 hour, depending upon the amount of urine output. Sometimes you can have a, this is the how the stoma is created. You can see the, you can see the ureters are anastomosed to this intestinal loop, and on the front, this is brought out of the abdominal wall. This is the stoma where the bag will be put. Then you've got a continent cutaneous reservoir, because the first was an incontinent cutaneous reservoir. So the urine will keep on coming continuously. Because it's a liquid form, the bag keeps on getting removed by an patients usually have a very difficult lifestyle, and this has to be there for permanently. It is not a temporary procedure. So that is why people have started developing continent urine cutaneous reservoirs. The most common is Indiana pouch. Here, the reservoir is created using cecum and ascending colon and terminal ileum, and the patient has, the urine gets collected in that reservoir. The cecum has got a good capacity. The urine will get collected, and you have to catheterize from outside. There'll be an opening in the outside. You just catheterize it, and the urine comes out in that catheter. So every 4 to 6 hours, you can put in a urinary catheter and drain the urine. But otherwise, the external opening will be closed. There's a valve-like mechanism. Because of the ileocecal valve, the valve-like mechanism will be there, and it will not be producing urine in a continuous manner in the uh, as totally. So see this, I mean the cecum and the ascending colon will be used as a reservoir, and this terminal ileum will be what, which will be catheterized. So you put the catheter till the cecum. There's an ileocecal valve which will prevent the urine from coming out as in a regular manner. And the last is an orthotopic neobladder. So for malignancies, people are doing it, but because of the risk of local recurrence inside that site and difficulty of finding out, diagnosing a local recurrence, sometimes it is not a very preferred method. So orthotopic means in the place of the old bladder, you create a new bladder. So a pouch is created using the small intestine, and and it is anastomosed to the distal urethra which you have excised, and the ureters are then anastomosed to this pouch, and you put in a catheter through the urethra every time urine has to be passed. And sometimes if the sphincter is normal, the patient might pass urine normally also. So it is, the usual indication is to do it in a younger patient without any serious medical conditions. So this is the pouch which they have created, neobladder. So complications, this is the last part of the talk. So complications, infections, because this is urine which is getting collected in the intestine, so intestinal flora can cause infection, ascending in infection up to the kidney. Sometimes pyelonephritis is very common. Urinary tract infections are very common with a conduit. Sometimes the intestine may get obstructed. You can have leakage of the urine, so urinary peritonitis can occur. The ureteric openings may get strictured over a long time if you have not created it properly. Normally, when we create an ureteric opening, the opening is made very wide so that strictures don't occur. Seromas or hematomas can occur. Sometimes urine may leak in the localized area and cause a urinoma formation. So urinary calculi is very common with such urinary conduits. Reflux of urine inside the kidney causing bacterial changes is also very common. Renal failure as an end stage complication of all these things is a end stage complication. Then you can have a pouchitis, that is inflammation of the pouch. Parastomal hernias, stomal stenosis, which are common to any stoma, is also seen. But metabolic complication is the one which we are very concerned about. So hyperchloremic metabolic acidosis is very common in all the urinary diversions, especially using ileum. And since it's that's the most commonly studied metabolic complication, the prevalence is as high as 25 to 46%. So half the patients, 1/4 to half the patients will have this complication. And this depends upon the renal function of the patient. So this is because of the intestinal fluid and electrolyte exchange which occurs between the intestinal mucosa, because it's a permeable membrane where urine is now coming, which is normally not the content of the intestinal lumen. That is why this complication occurs, and the patients have to be counseled regarding this complication, and they have to give them as prophylactic treatment to prevent a metabolic acidosis when you send the patient, and tell the patient about the possible symptoms of this complication so that they can come back to you if they start developing this complication or they start developing a deranged renal function, and you can treat them early. The main mechanism is absorption of ammonia and chloride from the urine. Long-term chronic metabolic acidosis can also occur. This can lead to impaired bone metabolism and osteomalacia. So regular monitoring of pH, chlorine, bicarbonate, and calcium phosphorus metabolism is therefore essential for early diagnosis and treatment. Okay, thank you. That was the last slide. Any questions? Questions you are writing in the question board or in the chat board? Any questions? If you can unmute yourself, you can ask. I know that option is available. Treatment of reflux. Treatment of reflux. Sometimes you might have to, if it's a very severe reflux, you might have to reanastomose that urine. Sometimes we just put in a double J stent inside that side which is refluxing and bring it on the outside so that the reflux can be stopped. It's a difficult, let's not go into that. This is a very tricky topic. The outcomes of these surgeries and outcomes of these procedures is very equivocal. So it's a very difficult thing. Any other questions? Okay. Any other questions? Otherwise, we can wrap the session. Okay. Thank you.